Good morning, everyone. Hi, good morning. Morning, everyone. Thank you. Thanks for everyone for joining today. Today's talk is from the Division of Geriatric Medicine, but we're derooting a little bit today in terms of palliative care. So I've asked our guest speaker to talk about two very important P's in palliative care: pain and prognostication. So we struggle, I see when I do my rounds for pain care, how we manage pain. Do we assess it well? Do we use the right drugs? We don't have a lot at our disposal, but we always told, in a serious illness or end-stage disease, we need to start slow, go slow. How slow is slow? We're not sure. And then at the same time, prognostication. And that's a difficult part of medicine. We struggle with it because of various reasons. We're not sure how well predictive the prognostic tools are. We fear that it might jeopardize our patient-doctor relationship. Just the other day, I think it was this week actually, I was told of a colleague at the UK. She had a patient who she predicted a 1-year mortality after being diagnosed, or 1-year life expectancy after being diagnosed with severe cancer. And so 1 year later, the patient came back with a written complaint against the doctor saying, I'm still alive. So it can go either way. And to help us manage these challenges, I have our guest speaker today, Dr. Charmaine Blanchard. She is no stranger to WITS. She's been the director of the Center of Excellence for Palliative Care previously at WITS Center at Barra. She's currently the clinical researcher at the Strengthening Oncology Services Research Unit, and she's co-authored in many papers and work related to cancer pain, and also the lead development of the National Policy Framework for Palliative Care. So it's a real honor to have her today. Thank you so much.
Thanks very much, and I really appreciate this opportunity to talk. And so I hope I'm going to be able to help with managing pain and prognosticating, because I agree with you, they're very, very difficult. And I think the assessment of pain is also being able to assess it properly is key. There we go. Okay. All right, so just some of the principles of pain management. Obviously, assessment and regular assessment. An assessment it's a more detailed assessment than we would do in a quick OPD clinic. Do you have pain? Where is it? When did it start? Okay, how severe is it? We kind of do have to know more detail about, how does the pain feel? How long have you had it? Does it come and go? So we add more detail because pain, as you'll see, as you can see here, is nociceptive and neuropathic, and then we have what's called psychogenic pain. And so by doing a more detailed pain assessment, you can identify what type of pain the patient is presenting with. For instance, the burning, tingling pain we know is often a neuropathic pain. The sharp pain that radiates down the limbs is possibly more neuropathic pain, whereas a nociceptive pain is going to be that gnawing pain, that deep pain, that ache. So we need to know what it is because we use different analgesics for the different pains. Psychogenic pain is also very real. When I worked in a very rural primary clinic, the most common complaint was waist pain. So the nurse would write on the patient's card, waist pain, and my heart would sink because I knew most of the time I would find nothing wrong. And this was just because of the stress of their lives and the depression and anxiety, they would manifest as waist pain. Other psychogenic pains would be headaches, tension headaches. And I've seen in patients where they have huge psychosocial issues and stresses that it actually upregulates their pain. And so we've at times been treating pain and the patient almost reaching toxic levels. And when we come down on the morphine, bring in a social worker to sort out their social issues, we find that their pain actually drops. So it is very real. I know sometimes it's hard to get your head around it, but it actually does work. It does happen in palliative care. And then obviously we want to reverse reversible factors first. If there's something that's causing the pain that we can reverse, that's first prize. We obviously treat the pain until that has been reversed fully, and then obviously you come down on your pain management. Non-pharmacological interventions, I don't think we use them enough. When we're working in community palliative care, we often use it more because it gives families things to do, warm packs, rubbing, massaging, all of that. And then obviously for our more high-income patients, we can try acupuncture and those other non-pharmacological interventions. And then obviously the support, as I've mentioned, the psychogenic pain. Good communication is really important, especially when it comes to explaining the medications and the dosing to the patients, because often when they come back and say, my pain is still bad, the first question is, are you taking the pills? How are you taking them? When are you taking them? And sometimes we find that is the cause of their continuing pain rather than the medications not working. Okay, so this is just again, a quick overview of where your pain is. So you've got the physiological pain. There's the sensory sort of aspect of pain, so that's what they're feeling. Cognition. So someone having pain in the chest, might think it's heartburn, and we'll just give something, for the heartburn. Someone else might think, oh my gosh, I'm having a heart attack. So their cognition around the pain is actually going to impact on how severe they experience the pain. We always say pain is what the patient says it is. So that can actually impact on what they assess their pain to be. And then obviously there's behavioral pain behaviors, social cultural. It obviously impacts on their relationships and their culture impacts on how they manage their pain. And then the affective, how it affects them psychologically. I've put up a cancer pain slide. Obviously, pain is not only in cancer. This is 90% of what I do. But I think it's a really important, it's important to understand pain in cancer. So what does this have a, I don't know if this shows, no. So the different types of pain, you have your intermittent pain, your continuous pain. So it's, oh, there we go. Thank you. Okay, so for timing of pain, it could be intermittent or continuous pain. And this is also important to know in terms of how we're going to manage the pain, because continuous pain, we're going to give regular dosing of analgesics. If it's intermittent, we will treat the pain PRN or find out what it is that's causing it. Acute and chronic pain, we will see in cancer. So they may have tumor-related pain or treatment-related pain that's chronic, but there may be other diagnostic interventions or treatments that will cause an acute pain. And remember, these people also have the occasional headaches and GIT infections and stuff that are going to cause pain as well. And then you have either your nociceptive or neuropathic pain. And I'm sure you're all aware of the types of pain, the nociceptive and visceral pain, the inflammatory pain, and then the neuropathic pain. What is really important to understand is the mixed pain syndrome. So we are seeing this quite a lot in our cancer patients. They will not have only nociceptive or only neuropathic. Because if you think about where the tumors are, for example, a pancreatic tumor, it's sitting close to all those, that plexus is sitting close to all those nerves. So often it's a mixed pain. So you may find that your opioid is not working so well, but it's because you're trying to treat a neuropathic pain with opioids, which it's only partially responsive to. So by adding a co-analgesic, you start to get better pain control. How do I get this? There we go. Okay. All right. So the step ladder for pain, I'm sure, are you familiar with the step ladder? Most of you. Okay. So obviously we start with step one, your non-opioids, we maximize step one, then we move to step two, maximize step two, move to step three, and then some people will add a step four, which is your invasive pain management. These are your pain blocks, the intrathecal pain management. So I'm not going to go into that. That's the area that anesthetics manages. But what was interesting is, so we traditionally would use paracetamol and ibuprofen, but not for a really long period. The ibuprofen, obviously, we've got to be careful of. And then we jump up to either codeine or Tramadol. We maximize that, and then we go up to morphine, which in the state, that's the only strong opioid we have. But obviously in private, we have other strong opioids we can use. But it's very interesting because Tramadol is not a very nice drug to take. I don't know if any of you have had Tramadol before. It can make you extremely nauseous. It's not a great drug to take. And what has been found is that there was a study done by Falek who found that if you step from step 1 straight to step 3, you actually get better pain control. So I find that really interesting. Obviously, you start with lower doses of your strong opioid than you would if you step from step 2 to step 3, but you actually get better pain control. So this is interesting because I'm not sure about the patients here, but certainly in private, if I go from Panado to morphine, they go, oh, morphine, I'm dying. I don't want morphine. So I find for some people, you have to use step 2 because we say, oh, well, Tramadol's just for that slightly stronger pain. And then when we need to step to morphine, then we say, well, the Tramadol was actually a weaker type of morphine. Now we're stepping up. So it's important to understand that you don't have to use the step 2. You can step directly to step 3. Some of these principles, you must, wherever possible, give pain by mouth. I know sometimes people do IVs and IMs. It's oral analgesics are the best. You give it by the clock. So this is where you need to counsel your patients and even the nurses in the ward sometimes. The pain must be, the medication must be given by the clock because this is chronic pain. It's never going to go away. If we try and treat this PRN, what happens is they have these pain spikes and you don't get good pain control. So they have to understand that it's by the clock. And then by the ladder, which makes sense because that way we are less likely to overdose our patients on strong analgesics, and always individualize the treatment. So different patients will respond differently. The standard morphine dose is, say, 5 milligrams 4 hourly. But if you've got a really elderly, frail patient, you might want to drop that to 2.5, even though the guideline says 5. Some patients, I've had patients who sometimes are fast metabolizers. So MST is normally given 12 hourly. I have patients who need it 8 hourly because they always get this end of dose failure. So a couple of hours before their next dose, they always have pain. So when we bring in the 3rd dose, they then get better pain control. So you have to individualize patients' treatment. Again, I think you're probably familiar with what most of these medications. So the paracetamol is your 1 gram up to 4 a day. The anti-inflammatories I only use if I really need them for bone pain. I don't like anti-inflammatories, obviously, for the obvious reasons of their side effects. And if I do give them, I give a PPI as well. Weak opioids, codeine, it's hard to get codeine in its pure form. We normally get it in those combination tablets, which are not ideal because the opioid, the dose in those combination tablets is actually too low to effectively manage pain. And the paracetamol, often in those combinations, stops you from giving them more because they're going to overdose on the paracetamol. So I prefer to not use combinations unless there's a good reason to. And then you've got your strong opioids, morphine and MST. And then one thing to remember is when we are prescribing opioids, even if it's codeine and Tramadol, we must prescribe a laxative. It's the one enduring side effect. And I've had 1 or 2 patients with terrible fecal impaction because they were not given laxatives and they didn't think to come back and say, I haven't had a bowel movement for a week or 2. So laxatives are really, really important. So as I said, if you are going to start with morphine syrup, this is assuming that you have maximized step 2 with your weaker opioids. So what we normally do is your patient is, it says opioid naive. Yeah, if they're opioid naive, you drop it. But normally we start with 10 milligrams 4 hourly. And they need to take it 4 hourly. They can't take it whenever or 6 hourly. And then what you can do is sometimes I start with that first and I find out what's the ideal dose for the patient, and then I switch to the MST. So you take your 24-hour dose. So if they're taking 60 milligrams a day, it becomes MST 30 milligrams 12 hourly. Sometimes you don't have the luxury of morphine syrup, but you have MST. I then would start with 10 milligrams of MST, 12 hourly, and work up from there because you don't quite know how they're going to respond. So that is your individualizing treatment. And as I said, if your patients are frail, you might want to start with a lower dose. Also, when your patients have severe COPD and severe respiratory distress, I also start with a much lower dose of morphine because we know it represses the respiratory function. But so I would sometimes even start with like 1 or 2 milligrams if those patients, because I don't want to put them, you know, to give them an overdose. And then your laxatives, as I said, antiemetics. So morphine can cause, or all opioids can cause nausea for the first 5 or 6 days. So I normally give them a PRN antiemetic. I say the first sign of nausea, you take this, metoclopramide or haloperidol. We can't get any more. I don't know. Do you have it in this hospital? You do. Oh, it seems to come and go. In private, it's there, and then it's not. Okay, and then you have to regularly assess. So when you see them again, how's the pain? How's it doing? Obviously, in palliative care, we have regular access to our patients. But regularly assessing and then adjusting the doses. If you need to increase, 30 to 50% increases at a time, no more. And then wait a day, see how it is, and then increase again. All right, I just want to say here, so the transient side effects are the ones that are the nausea and the drowsiness. So people feel that morphine is going to make them very drowsy and they're not going to be able to function. So we warn them, you will feel a bit drowsy initially, but that will wear off, as will the nausea normally. And we normally say to them that, you know, it's a nice little pain holiday. So every time you increase the dose, they may have these side effects again. The constipation is the permanent side effect. They're very rare that we have patients who do not have constipation unless they have high output stomas or other causes for diarrhea. Opioid toxicity may occur, and if you see they often have myoclonus, they're agitated, they may have frightening hallucinations, so we then have to reduce the dose. Sometimes if it's essential for pain, we then treat the myoclonus and the hallucinations. So we manage the side effects if we cannot come down on the morphine. And then opioid overdose, I have only ever seen one of overdose, which was a woman who was on the 3-day opioid patch. And you're supposed to only increase that every 3 days, and it was being increased every day. So she went into overdose, and we had to look after her in ICU, and luckily she recovered. Opioid withdrawal, so don't stop your opioids quickly because the patient does develop a physiological tolerance. It's a bit like the corticosteroids. So when you are going to reduce the opioid, you have to reduce it by your 30 or 50% going down as well. So co-analgesics for pain. Are you familiar with this management of pain with the co-analgesics? I'm seeing some nods, some not so. Yeah, okay. So for bone pain, paracetamol works. If that doesn't work, then I would start a non-steroidal. Corticosteroids we save for if the non-steroidals are not working. So in a palliative setting, we would start some corticosteroids if we were not winning with our non-steroidals. Obviously, if your patient has a tumor-related bone pain, you can consider bisphosphonates. We often refer them for radiotherapy. Like one small dose of radiotherapy can really manage their pain well, and if necessary, surgery. But that's very rare that we use surgery to obviously reverse the reversible. Neuropathic pain. I know that you have carbamazepine. I know the EML's got carbamazepine and amitriptyline. And as far as I understand, some hospitals have access to either gabapentin or pregabalin. So this is for your obviously your burning, tingling, pins and needles type of pain. Patient can't bear the sheets and things on their feet or their hands. Or that central pain, which is that very sharp shooting pain. So when they've got nerve entrapment, then we use the neuropathic pain. We treat neuropathic pain. Amitriptyline I often use for the peripheral neuropathies, and because I have access to gabapentin, I use gabapentin for the more central neuropathies. And the carbamazepine I've rarely used just because I've always had access to gabapentin. But the carbamazepine is another co-analgesic you can use if that's what you only have access to. Colic, we use Buscopan. I think you're all familiar with that. And then raised intracranial pressure. So our patients with gliomas, astrocytomas, all of these brain tumors, as soon as they start getting really severe headaches, we're obviously using the opioids, but we always add some dexamethasone or prednisone, whatever we can use. And it really, really helps well. But just remember, it does cause insomnia. So we tell patients to take the full dose before midday. So if they're on quite high doses, we split it in a morning and a late morning dose because it does cause insomnia in many people. And the other thing I use it for is liver capsule stretch. So I've had some patients who've got malignancy, obviously mets in the liver, they stretch of the capsule and they complain of a really poor, really severe pain in their right sort of upper quadrant. And then what I do is I put them on corticosteroid as a trial for 5 days, in addition to the opioid. If their pain responds, then I taper it down to the lowest dose that manages their pain. Muscle spasms, obviously we're using muscle relaxant. And the incident pain, you can give morphine syrup an hour before they are going to have the procedure. So it might be wound dressings, whatever it is that you're going to be doing, you can give it an hour before. I've got a nurse who does catheter change for a really old man, and she does it every 3 weeks. And she says to the caregivers, give him his, just Panado, paracetamol. She gives it to him an hour before, and he experiences less pain with the catheter change. So it's about being aware and how you can manage people's pain. Again, this is the corticosteroids with some of the doses that are recommended. This is obviously in a palliative setting. In oncology setting, they use much higher doses. Again, it's for your raised intracranial pressure, spinal cord compression, or nerve compression. It's your capsule stretch. And then sometimes if you've got soft tissue infiltration with edema around that, you can use the corticosteroids. The general well-being, we use it sparingly for general well-being, because we don't want people to be dependent on corticosteroids. Makes them feel well, and then you take them off and they kind of crash. Because the side effects are I don't think the side effects justify them being on the corticosteroids for a long period of time. But sometimes for a short period, like sometimes they're waiting for someone to come visit, or they've got family and they want to feel well, then we'll give them a short dose, a course of corticosteroids, and it really does help. I had one man who had a brain tumor, so we were giving it to him for his headaches and pain, but it gave him an appetite. And then eventually the family were getting upset with me because he had an appetite, but he obviously was still getting progressively weaker and he was struggling to swallow, but he was hungry. So they said, can't we stop the steroids? Because the steroids are giving him an appetite, but it's too weak to eat. So there was a whole discussion around that and how we were going to manage that. So for me, it was really something that I realized you need to think about when you are using medication. What are the unintended side effects as well? This is the, if you're looking at neuropathic pain, this comes from our South African guideline for the management of neuropathic pain. I think it's a nice little questionnaire. You can download this, looking at trying to understand whether this pain is neuropathic or not. So you've got the different characteristics of the pain, the symptoms that are associated with the pain, and then just a very quick physical examination. And then you give a score, and if the score is greater than or equal to 4, your patient has most likely got neuropathic pain. Again, this is just how to manage neuropathic pain, and this is some of the, so you use your gabapentinoids, or you can use SNRIs, and then I know here, unfortunately, I don't think you have SNRIs, but they are really, really helpful. Or you could probably try the amitriptyline, and then you just need to reevaluate, and you've got to give it time to work. So you need to reevaluate after 2 or 3 weeks, and then you can either increase the dose or you switch to another class if it's absolutely not working. And then this is for central neuropathic pain. For me, as I say, I find the gabapentin or the carbamazepine will work better for the central pain, and amitriptyline works better for the peripheral neuropathy, peripheral neuropathic pain. I wanted to just touch briefly on serotonin syndrome, because I think it's a very rare side effect, but it can be devastating. And in palliative care, because we are using a lot of medications that will increase serotonin, we've got to be careful of the combinations. And so this is the excessive serotonergic activity, and it alters mental status. It causes autonomic dysfunction and instability and neuromuscular excitation. It can be mild or it can be life-threatening. The mild cases probably aren't really picked up. And it normally starts within a day of adding another drug or increasing a dose. And I had a lady who was she had colorectal cancer. We were managing her pain with Trammel. She didn't want to do morphine. No, we were managing it with paracetamol, and she had some codeine. We were giving her gabapentin for neuropathic pain, and she was on an antidepressant because of, obviously the oncologist had given it to her to manage the depression associated with her disease. And her pain started increasing, and we switched to Trammel. And within a day or two, she had these big staring eyes. She started sweating a lot. She was getting quite confused. She was having muscle twitches. Day 3, she started getting cramping of the abdomen. So this is really a clinical diagnosis. And so she was starting to show a lot of these symptoms, and I was concerned. So I spoke to her geriatrician actually and said, please, what do we do? What can I offer her for pain? Because obviously when we added the Trammel, it tipped her into the serotonin syndrome. So the other option was morphine, but morphine also can cause serotonin syndrome, but to a lesser extent than Trammel. So what we did is we dropped the gabapentin by 1 dose, and we then switched the Trammel for a low dose morphine, and it certainly improved. Then later on, a few weeks later, she started to develop the symptoms again. And what we did is we then halved her antidepressant, dropped another dose of gabapentin. She was still managing her pain, and upped the morphine slightly. So it's a case of working. So it's really removing obviously removing the serotonergic agent. Obviously giving supportive care. You may need sedation because of the muscle spasms. And then you obviously need to monitor vital signs. The other thing, her blood pressure was shooting up, her pulse was everywhere. And if there's hypothermia, she had this diaphoresis, high temperature, you obviously need to address these. And in the extreme cases, you can use serotonin antagonists. I've only ever seen 2 of these cases, this one, and then probably about 12, 13 years ago, I had a young girl who presented with a similar scenario. So as I say, it's rare, but in palliative care, when you start using a lot of drugs that can affect your serotonin pathway, I think it's just something to be aware of. And then obviously we have the psychosocial interventions, and this is where we use our social workers and counselors, and there are various therapies. The counseling works really well in our patients. Just having someone to explain, to listen to them, to help them with coping methods with pain can really be very helpful to our patients. And family therapy is also really helpful, because a lot of these people, there's a lot of family conflict. This one wants this one wants that. This one says supportive care only. This one says we need to treat and go to hospital. So there's a lot of conflict which impacts on the patient and affects their pain. So it's important to manage the family as well. This is just again because I work mostly with cancer pain, but obviously a lot of this can also be translated to other painful syndromes. So obviously your pharmacological agents is your opioids and non-opioids and adjuvants, and then your non-pharmacological is obviously using physiotherapy. So most of our patients, again, because they have access to funding, will get a physiotherapist to work with them once a week, just to make sure they're doing the exercise and to see how they can reduce their pain through physio. Obviously, targeting the cause of the pain is important, reverse the reversible, and then your behavioral psychotherapy. And for more chronic pains, so your patient who's still got a reasonably good prognosis, you might want to see a psychologist who can help them with cognitive behavioral therapy and find ways to manage their pain better. You don't want them, relying on the opioids for the rest of their life. And then just briefly, spinal cord compression, especially your patients who are at risk of bone metastases. Pain is always the first symptom. I remember Prof telling me many, many years ago, he said, pain is the first symptom. If the patient has back pain and starts developing any neurological signs, you have to have a high suspicion for spinal cord compression. So any pain that is increasing in severity and there's a risk of a tumor or a spinal cord compression, you must have a low index, you must have a higher index of suspicion and just investigate it. This is in the pain guide, so it's available online with Pain SA, and it really just is it's a summary of how to manage pain. So it's the assessments of pain, and then the baseline management. This is for oncology as well. So you've got your non-pharmacological and then your oncologic interventions, and then you have your WHO step ladder over here. So this is for your paracetamol and your opioids, and then you have your neuropathic pain step ladder over here. So it just gives a nice summary of the pain management. Okay, so I just want to go into prognostication, because I hear it is difficult, and even for us, we've been working in this field for many years, we still get it wrong. So don't feel like you don't know what you're doing. It's really hard to prognosticate. So the problem we have is obviously their prolonged hospital stays when people should be going home. They might end up in intensive care because people are not realizing that they're reaching end of life, and then all the things that start happening are just now trying to be treated in an intensive care situation when actually it should be treated at home. Sometimes patients don't want life-sustaining treatment, but no one's had this discussion with them about their prognosis because either we've missed it or we're too scared to actually talk to them about it. And then referrals to palliative care occur very late. And it's often when it's obvious the person's dying, when maybe they should have been referred a few weeks earlier, they referred in the last couple of days. So there were this study that was done by Scott Murray. His initial study was he looked at, retrospectively looked at records in a GP, in a general practice, and looked at their trajectories before dying, because these people, it was in the UK, so they were having regular visits with the doctors, and he managed to map trajectories. This one is a little complicated. It's just, I want you just to look at the physical here. So this is a patient with cancer. They get diagnosed, there's a bit of a dip in function, they're fine, then they get a recurrence, a dip, they may get a bit of treatment to manage the recurrence, but now they're on life-extending therapy or their chemotherapy, and that might stop. They're pretty well, and then there's a very sudden decline. And I've just had a lady now who, we saw her, she was walking, she was going to work half day, that was 3 weeks ago, and she passed away 2 days ago. Very sudden, and it was, even caught me by surprise, but it's not normally that dramatic, but certainly what you see is the decline is over years, then it starts to become months, you're seeing a regular decline, then you're seeing a decline over weeks, and then days, and then obviously hours. So it's quite predictable. When that person starts losing function, you kind of know where you're going. Your organ failures are a little more difficult to predict. So you still have your general decline, but you're going to have acute exacerbations, hospitalization, optimized, go home, fine, another hospitalization. And so you never know which one of these is going to be the final one. So it's a lot more difficult to prognosticate. And it's harder for families as well because there's more uncertainty than there is with the cancer. Frailty and neurological conditions. So the patients start from a low base already. So these are your frail patients that just trundle on, maybe develop a bit of dementia, and then they just trundle on. They have one or two events which may make things worse. And then eventually they trickle and they start having less appetite, less interest in life until they finally pass away. So you can see, and then you have multimorbidity where you have a patient with more than one illness. And you can see it's much more complicated. So you have declines, patient has a stroke, they improve, then they have a hip fracture from a fall. There's admissions to care homes, possibly. They have a lot of psychological distress as well because of the loss of control and stress about, some of them are worried about how they're going to be able to afford their care. So this is a much more complicated, and this we see a lot in our geriatric patients. I was saying to Anu, we get quite a few referrals now from geriatricians because we do such a good job of home care. And I'm finding this a whole new space for me because I was used to mostly cancer, a few of the organ failures, and suddenly I've got a geriatric patient with about 5 morbidities and hundreds of medications, and this is a much more difficult field to navigate. So generally we are over optimistic because we want the best for our patients. We don't want them to die. We kind of are trying to be hopeful. But what's really important, as you can see from those graphs, is this ability to function. It really is the most powerful prognostic tool because it sums up all the physiological processes that are happening in our bodies. So you can use a whole lot of there are no real markers that can really help. One of them is albumin. I use that a lot. So if a patient's albumin starts dropping, when you're starting to get into the 20s, you're getting towards months or so. When you're going below 20, you're kind of getting into weeks or so. So I find albumin a really nice marker. Some people use CRP. So with increasing CRP or white cell count, you're starting to get inflammatory processes towards end of life. But for me, those are not as accurate as just looking at ability to function. So this is as you said, there are many scales that we can use to prognosticate and understand where our patients, how much longer they've got to live. So the ECOG performance scale is your Eastern, what's it called? Eastern Cooperative Oncology group. So this scale we used for a long time. I still find it very useful because it's simple. It's got 4 or 5 numbers. It's easy to remember. For us with cancer, when your patient starts getting to stage 3 or ECOG 3, you're looking at months to live. So a lot of the palliative care providers and the funders that fund palliative care in private, when your patient, if the oncologist says the patient's ECOG 3, they're more likely to fund them for the palliative care benefit. And I do find if they're sitting at 1 or 2, you're probably looking at a year or so, maybe a couple more, depending on the diagnosis and the aggressiveness of the cancer. When you start getting to 3, which is where they're only capable of limited self-care, they're in bed most of the day, you're moving into months. 4, when they're completely disabled in bed all day and really struggling even to feed themselves, you've got weeks to go. So it really is quite a nice rough guide. The Karnofsky performance scale is similar, except it's got a lot more numbers. So I find this very difficult to remember. But again, it basically follows the ECOG. So if you want to be more precise, you can use the Karnofsky performance scale. And then this is called the palliative performance scale. These scales, the ECOG is probably a more general scale. These are more for patients with cancer as well as chronic disease. And you can see it goes from 100% where they're fully functional all the way down to obviously death. So it's similar to the Karnofsky scale, but they're looking at a lot more. They're looking at ambulation. They're looking at what's the disease activity? How can they take care of themselves? They include intake, which is not included in the ECOG or the Karnofsky scale, and then their consciousness level. So what I'm trying to say is there are a number of different scales you can use, and they're all pretty accurate. It's a matter of what do you prefer. So I like the ECOG scale because for me it's quick to assess, and then I also take into account intake. Because as people get closer to death, they start eating less. And your older, frail patients, the families will say they're just not eating enough anymore. They're giving up. And it's just another indicator of the patient approaching end of life. So this is the one where I don't, as I say, this paper here, they looked at hemoglobin and we're looking at what were the factors that, which were the factors that predicted death. So they were talking about neutrophil counts, the albumin here, obviously if it's 25 or less. They were looking at lymphocyte counts and platelet counts. Personally, I don't use this because we don't do bloods regularly in palliative care. You kind of trying to avoid those. But if you're in a hospital and you've got a hospitalized patient, you can look at some of the bloods and say, is this a picture showing that this patient is nearing death? This is a South African tool. It was developed in UCT. So they use this in their state hospitals when they are assessing patients for palliative care. It's a very busy tool, so I try to break it down a bit. So these are more the general indicators. So again, it's unplanned health facility visits if there are more than 2 a year. Their performance status is deteriorating. And again, dependence on others. So it follows the same as that Karnofsky scale and the ECOG scale. And they include weight loss, obviously, as people get closer. There's a lot of sarcopenia as well. So people can look quite chubby, but actually they've got a lot of muscle wasting underneath that. When I was first starting in palliative care, I had a lady with breast cancer who looked really well covered, and then she died, and I was shocked. And then what I realized, when I read it a bit later, and I was learning more and more, that she had sarcopenia under that. And if you go and look at serial CT scans, which they do in the States a lot, you will see that they maintain that body fat, especially breast cancer patients. But you can see on the CT scans how their muscle mass has been reducing over time. So weight loss or sarcopenia is also an indicator. And then I'm not going to go through this, but it is available. You can get it online. You can see that there are indicators for each disease. So if you're a nephrologist, you can look at kidney disease. If you're dealing with hematological diseases, you can go and look at those precise indicators for prognostication. So essentially what I'm saying is prognostication is still quite difficult, especially if you look at the trajectory. Some of those more uncertain trajectories, it is more difficult. I've had this lady, twice I've prepared the family. I'm saying she's going to die. We're entering the last days of life. And she perked up and she was fine. And this was a cancer patient. And she's done it to us twice. So now I don't actually say, I say, well, let's see, let's take it day by day. So there's a general rule of declining ability to function, weight loss, less appetite, and if you've looked at all the reversible causes of that, more sleepiness, more sleepiness, decreased urine output, more disorientated, then you know that that patient is getting closer to weeks to live. When they're getting closer to death, they often get very confused. What I do see a lot is people they get up at night. They tend to want to go to the bathroom like 3 times at night, but then when they get there, they say, no, I don't need to go, and they go back to bed. And this is part of what we call pre-terminal restlessness. So when a person is getting towards that terminal stage, days to live, they go through a period of agitation and anxiety and stress. Even people that say, I'm ready to die, I'm comfortable, I know where I'm going, they sometimes go through that period for about 48 hours or so, and then after that, they seem to then deteriorate completely and go into a coma or just sleeping all day. So that agitation and restlessness that you see. The other thing they do is they will see people in the room that nobody else can see. I don't know if you've experienced that. They may talk to someone who's in the room. They often use language like, we need to pack our bags, or I want to go on a trip. So they use this kind of language that means they are leaving, they're going somewhere. Or they say, I want to go home. I had a guy who kept saying, I want to go home. And I said, but you're at home. He says, no, I want to go home. And I said, do you want to go home? And he said, yes, I want to go home. So, and that's the kind of thing, but that's obviously getting much closer to the actual death itself. I think that's the end of mine. And then we are going over to Nicole.
Before that, thank you, Dr. Blanchard. It's very informative. I think so. I have a few questions, but before that, anyone on the floor?
There's obviously with things happening in the States, we've seen it a